Greetings, everyone, and welcome. Thank you for joining the NCI Global Cancer Research and Control Seminar today. I am Mishka Kolisira with the NCI Center for Global Health. It's my honor to facilitate today's seminar, which will be delivered by Dr. Christian Ntizimira. And the title of the session is Constructing a Culturally Sensitive Palliative Care System, the Importance and Methodology of Collaborative Design with Rwandan Community. First, let me tell you a bit about the series, a bit about Dr. Ntizimira, and some logistics for the session. So in 2021, in celebration of the Center for Global Health's 10th anniversary, we launched this series, the NCI Global Cancer Research and Control Seminar Series, and is meant to feature talks by researchers and cancer control experts working in global oncology, and also to provide opportunities for discussion and collaboration on impactful and innovative work that's addressing cancer morbidity and mortality worldwide. So today we're really delighted to hear from Dr. Christian Ntizimira. Dr. Ntizimira is the author of The Safari Concept, an African framework on end-of-life care. And if any of you are in any areas of social media, you probably have seen a lot of really interesting outreach from folks who have been very excited to read his work. He's also founder and executive director of the African Center for Research on End-of-Life Care, and which is a nonprofit organization to bring socio-cultural equality through Ubuntu in end-of-life care in Africa. Dr. Ntizimira is a Fulbright alumni and a graduate from the Harvard Medical School Department of Global Health and Social Medicine. He's also an alumnus of the Kofi Annan Global Health Leadership Program, which aims to bring selected Africans to strategize, manage, and lead public health programs that will transform public health in Africa. Dr. Ntizimira is also winner of prestigious awards, and in the interest of time, I will want to give an opportunity for him to share more about his background as he goes through his talk. But before turning the microphone to Dr. Ntizimira, I'd like to review a few logistics for today's session, especially for those of you if this is the first time you're joining us. So please save your questions for the designated Q&A time immediately following the presentation. You can type your questions in the chat or use the raise hand feature under reactions during our discussion period. Please note the session is being recorded and it will be available on our website, which is cancer.gov/globalhealth. You can also find information about future presentations on our website and by following us on formerly known as Twitter and at NCI Global Health. And we'll now begin our presentation. So welcome, Dr. Ntizimira, and over to you.
Thank you, Mishka, and thank you, Nina, for the invitation. Good morning, good afternoon, good evening, everyone. It's a great pleasure to be here and share with you our small experiences from Rwanda, and looking forward to hear your question and comments about our presentation. So allow me to share my screen. Yeah. Can you see my screen?
Yes, looks perfect.
Okay. So I'm going to talk about constructive culture sensitivity, why it's really important to, in palliative care especially, social culture is really important. And from my experiences, from my lessons learned, from also my mistakes, I would like to share with you some of the experiences. And especially when using in Rwanda context, why community, why in Rwanda, we focus on community. Why community is so really important. So I hope by end of this project, we'll be able to understand cultural sensitivity in palliative care, learn about our culture, values, belief, and practice in Rwanda, which shape patient and family involvement, understand also Ubuntu philosophy, why Ubuntu philosophy, why this philosophy can be a game changer in palliative care and end-of-life care, not only in Rwanda, but also in Africa, but also even in general as an experiences. And also we explore some of the model of cultural sensitivity palliative care in Rwanda, we're trying to develop with colleagues from Africa, but also from US. So community as a country. So I live in Rwanda. Rwanda is the land of thousands years. It's one of the smallest country in Africa, but not a small nation, located in Eastern Central Africa, Great Lake region. Almost 13 million people live in the country, but 50% of our population is under 20. It's a very young country with a huge density, around 500 people by kilometer square. And it's a landlocked country, but a majority of export and earning and labor attributed to agriculture. So this is now 30 years after the genocide against the Tutsi, where 1 million people died in 100 days. And it's not only 1 million people died in 100 days, but we lost also, humanity itself seems lost that time. And I strongly believe that the concept of palliative care will contribute a lot to bring back the sense of humanity lost during the genocide. Why? Because palliative care, on my understanding and my opinion, is not only about withdrawing or withholding medication, it's more about humanity, dignity, and Ubuntu. So community in the background of palliative care. How was palliative care after the genocide against the Tutsi? So between 2007 and 2009, a small study has been done by the University of Wisconsin, the Department of Penn Policy Study Group. I think it was among the few studies done that time. And it showed that the morphine equivalent using that time was only 0.2 kgs of morphine. And per capita per milligram, if you can understand, was less than 0.1. And 0.2 kgs, it was enough to treat only 27 people. And the coverage of death in pain of treatment was only 0.2%. So the estimates done from the study that Rwanda need approximately 97 kgs of morphine. So you can imagine a number of patients, especially HIV/AIDS and cancer patient, was really suffer from moderate and severe pain, more than 85%. So what was the challenges that time? One was apophobia, fear to prescribe morphine. And it's here there is this big myth at that time about if you prescribe morphine and the patient die, you're going to jail. So physician feared to prescribe morphine. And also the attitude, the doctor attitude regarding pain. I remember when I was in medical school, one of my teacher used to tell us, please don't treat completely pain, because pain is the best signal to tell you that your patient is alive. So if you treat pain, how do you know that your patient is alive? So the attitude regarding pain was totally how can I say, was confusing and was wrong that time. And also the protocol for using morphine. For those who want to try to using morphine, you need a red ink and 3 signatures for just 1 amp of morphine. So if you need 10 amp of morphine, how many signatures do you want? I'm sorry, I was not good in math in school, so you know how many signatures people will need. And also no multidisciplinary approach to support patients. It was in 2011 when the government of Rwanda, after the experiences from HIV/AIDS patients, decided to launch a standalone palliative care policy, which made Rwanda the first African country to launch a standalone palliative care policy, a strategic plan for 4 years, and an implementation plan to make sure that patients, that time was the HIV/AIDS and the cancer, will get a palliative care program and services at the health centers. And that changed completely the paradigm of taking care of patients with palliative care. And after that, after the training of physicians, how they can start prescribing morphine, Rwanda decided to produce its own morphine and they decided to choose morphine syrup. So what the government do, they imported morphine powder, and then the reconstituted morphine powder, as you may see in a photo, and they reconstituted in the country, 5 milligram by 5 milliliter, and oral morphine is free of charge to all patients who are part of the palliative care program, and also those who suffer from moderate and severe pain. So as you may see, that was changed completely the way of doing palliative care in the country. So we moved from 0.2 kgs of morphine that time to almost between 5 to 15 kgs of morphine. Of course, the estimation from the study requests that Rwanda needs approximately 97 kgs of morphine a year, but we are grateful from the big step have been done by the government to move from zero morphine available in the country to almost 15. And we hope when physicians will continue to be trained, and that will increase, of course, the quantity of morphine, and they will remove the myth beyond using morphine and opioid in the country. And also one of the biggest steps is the law governing narcotic drugs, psychotrope, and substance and the precursor in Rwanda, based on the experiences of the task shifting from the task shifting when nurses can prescribe ARVs, the health centers. The government want to use the same experiences to allow nurses, midwives, clinical officers who are not physicians and trained to prescribe morphine to be able to prescribe morphine at the community. I mean, the idea here is to move the services at the community level and to avoid patients to come back at the hospital to get some prescription of painkillers. So and the part of that, and the government, the vision of the government is the community, and Rwanda want to hire more than 1,000 palliative caregivers, and making sure that patients will receive, when patients will be discharged, patient will get all the support, physical, psychological, social, and spiritual at the community. And that will make, will bring back, as I'm saying, the dignity, the sense of humanity, and Ubuntu of the patient at home. So this is briefly the program of palliative care in Rwanda. It's very comprehensive in terms of policy and the government, education and training, drug availability, as I mentioned, clinical care assessment, monitoring, evaluation, and now through this organization, the African Center for Research on End-of-Life Care, we would like to continue to increase our skills on research and make sure to really understand how end-of-life care will be well addressed in Rwanda, not only in Rwanda, but also in Africa. So community has a personal story. After the genocide against the Tutsi, my dream was to be a surgeon, because I've seen some realities post the genocide, until I met a very young guy, 24 years old, who was really dying in pain. And that time, I feared to prescribe morphine. Morphine was available in the hospital in small quantity, but I feared to prescribe morphine, because if I prescribe morphine, behind that myth, that I would go to jail. So I didn't prescribe morphine at all. And the young man was really screaming in the room. And the whole family was out of the room, because they can't deal to see the young guy was really screaming and suffer. But the sad story, his mom came to me and kneeled before me and asked if I can do something for his son, then he can sleep and wake up normal. I felt that I failed twice. I failed as a physician because I feared to prescribe morphine, but also I failed as a Rwandan, because in our culture, when you see elder person kneel before a young person, culturally, you failed. So I went back home and questioned myself, what the reason I spent so many years in medical school? And if my role is just witnessing the suffering of the patient, what the reason to do medical school? If my role is just witnessing someone who's dying without any assistance, what the reason to wear a lab coat, a white lab coat and a stethoscope, working in the hospital, if I can just witness people who are dying without any support? What the reason to be a physician if it's just to collect data? What the reason, what I'm doing? And the next day, I moved from my dream to become a surgeon. And I shifted to be to be a palliative care passionate. Community in the context of death and dying. So my time in Boston was really interesting, and I thank all my directors and supporters and supervisors. And I did my thesis, try to understand what was end-of-life care in pre-colonial and post-colonial, what we gained, what we lost at that time. And what I just realized, death in pre-colonial period, death was viewed as an achievement. I hope this paper will be published next year. So death was viewed as an accomplishment because it was considered as part of a normal life, a natural phenomenon. It was viewed as a natural reprieve and a reward after well lived. So it was not difficult for people to talk about death and a fulfilled life. And it was seen as a reward to be a spirit, an ancestor. So it was a privilege for the family to be there when someone was dying, because that was preparing that person to be a spirit, to be an ancestor and protector of the family. So it's why in our culture, when people want to ask you your name, they don't ask you what's your name, but they don't ask you from your ancestor. They ask you from your family, from the name of your family. So the concept of good death and bad death was not only related on the physical aspect, but good death was viewed when the social culture engagement of the family members and the community during the death process. As I said, it was a privilege, not a hardship. And that time, having children was a criterion by which person in the society was judged, because it was representing the high achievement which defined good death. Because when when someone was dead before the rigorous process, rigorous mortis process, all the family need to be there and put the dead body on the position of the fetus in the womb. And that was judged as the good death. But when someone was dying alone and the dead body was not straight and the horizontal way, so people were saying this is a bad death. So the post-mortem ritual was very important for the family members to help the patient to the next step. But why death became a source of fear? So the adoption of Christian belief in the colonial period especially shifted the paradigm of death to the perception of end-of-life change. It changed completely because in the pre-colonial period, the concept of hell and heaven, which is bring a choice, was not familiar in the Rwanda tradition prior to colonization. Sometimes we think that choice, it's a good thing, but sometimes not in a different context. And death become as a penalty, a sanction, increasing fear and changing the perception of death during the dying process. And this is why when I'm teaching my medical student and say, you have to be there when someone is dying, because you need to make his death as an accomplishment. And you no need to fear that the spirit of that person will leave the dead body and getting in you. And you fear that that spirit will bring you to go to the hell or in the heaven. So that church completed the ritual of ancestors, which become now a ritual of evil. So community as a life until the end, the network. So during the COVID-19 pandemic situation, where it was challenging for everyone, our patients sometimes died without any assistance because we didn't know what is the COVID-19. And because in the previous years, there was an outbreak, Ebola outbreak in DRC Congo. And so people feared and said, maybe COVID-19 it's equal to Ebola. So we feared to see our patient. We fear to go and see our patient. So we were using on our phone. And unfortunately, an external funding withdrew that time. And it was really interesting to understand what should be the model, what should be the model will be developed to understand and will be sustainable for our community. And then we're starting to focus on three major, from our experiences, how to reduce time, how to reduce distance, and how to reduce cost. And we came up with this model with our developed with a partnership with my director, Dr. Eric Krakow from MGH. So we took one district in the urban and one district in the rural. And we try to develop the same model and to understand what would be the best way to bring the dignity and the sense of humanity to our patient. And the lesson learned from the COVID-19, despite that the external funding withdrew, but care continues. But why care continues? Because care continues was because it was rooted in one of the strong philosophy we have in Africa in general is Ubuntu. And we use that philosophy, we use that common philosophy with that experiences from the COVID-19 to develop a different model in our country, which will be sensitive from our culture and bring back that sense of humanity I mentioned in the beginning of the presentation. So we came on this Life Until the End networking. We trained the district hospital, we trained the health centers, we trained the health posts, and we trained the community using community health worker per villages. So that will allow patients to move from the community to the health post and also to the health center and also to the district, just to avoid in terms of time, distance, and cost, to see the patient moving from all the villages and just to get some prescription at the district level. So this is some of our training made starting from one of the district. This is the urban area where we have the Rwanda Military Hospital, and one of the biggest cancer center, the Rwanda Cancer Center, is located. As you may see, we train the multidisciplinary team, oncologists, nurses, psychologists, and all the team to support the patients. And then we move at the district level at Masaka Hospital, District Hospital, and we train also the multidisciplinary team and make sure that at each level or the health system in Rwanda, patients will find information, will find services, and will find support. Because humanity deserves to every patient. And it's really important for when disease bring this sense of fractures to reconcile the patient to his community. So this is the training happening in the rural area at Byumba District Hospital. As you may see, we train also the multidisciplinary team, and also we train also community health workers. As you may see, we train one community health workers per village to making sure that the community health workers will support the patient at home. And also we train also volunteers or caregivers to support the patient and continue to support also the families in terms of counseling. So community as the lesson learned. So something I've learned from Rwanda, from the context, we have a saying, when you are well, you belong to yourself, but when you are sick, you belong to your family. So it's about patient autonomy and community responsibility. So in patient autonomy, you have the person, the expectation, privacy, and the community responsibility, it's a family resources and norm. So we need both in terms of decision making. It's not only about the patient's autonomy. Yes, the patient has to decide about the expectation and the privacy that has to be respected. but also in the other end, we have the community responsibility. So we're using the butterfly approach to make sure in terms of decision making, you need to remember our role is not just to prescribe, but also to reconcile between the patient and the community. Something I've learned from my mistakes when I was in Boston, come back home, want to duplicate the same model. So happy I've learned so many things from Boston, but unfortunately I failed. I failed because I created a conflict with my community, my colleague, my patient, and the family members. And I didn't understand that time that context matters. And then I just realized if you are well educated, doesn't mean you need to replicate it, the same model. Instead, you need to adopt before to adapt. I've learned sometimes when people say, oh, this is a great tool. Can you adapt it in your context? Yes, but before to adapt, you need to adopt. You need to adopt to the perception of care at the local context. Then you can adapt it to the current challenges. So then that's something I've learned. Before to adapt, you need to adopt. And also about the terminology. I mentioned about the life until the end network. In my context, in my language in Kinyarwanda, end-of-life care has no meaning. I'm using end-of-life care because this is an academic word. This is a universal word to help people to understand what I'm saying. But in my language, end-of-life care has no meaning. So we don't talk about end-of-life care. We talk about life until the end. And that is something really important. We will understand in the next slide about the Ubuntu philosophy. And understand context is really important. The current model of advanced care planning in Africa in general have grown up from the Euro-American clinical and the culture experiences. So it is really important to create a locally relevant community-centered model. So we don't use a patient-centered model because the patient has not excluded to the community as the community has not excluded to the patient. The patient is part of the community as the community is part of the patient. And that model value the culture, the identity of the patient. And also the meaning. Part of my ethnography work during my thesis project. So I understood that traditional palliative care and end-of-life care existed before modern palliative care exists. They didn't call it palliative care, but the same component of palliative care, the modern palliative care we have now, was existing before. And if we need today to create and to build a global community in palliative care, we need first to connect communities, but we cannot connect communities without connecting identities. And also, we need to not be trapped in international standard in oncology or in palliative care, where some critical elements are crucial for the dignity for the patient and family. Otherwise, this international standard becomes a source of a social injustice for the patient and for the family. As I'm saying about the Ubuntu philosophy, why Ubuntu philosophy? So contrary to the Cartesian philosophy, I think, therefore I am, Ubuntu is about I am because we are. It's not about me, it's about we. I am because we are. It's humanity toward others. So Ubuntu value life. And that is really something to understand, because in our concept, death is part of life because life never ends. So we don't value death. It's why when I'm discussing with my colleague, my European American colleague, when they say, oh, in Rwanda, you don't talk about death. It's not about talking about death. It's about what is how we value death vis-a-vis versus life. Because death is part of life, so we value life because life never ends. It's why people don't talk about death, because they value life. And Ubuntu value dignity, compassion, humanness, harmony, and reconciliation, as I mentioned. So in my research, what I'm doing, Ubuntu within the context of palliative care, try to understand that Ubuntu could be the response to suffering, the dignity of the patient, And also the social justice, patient versus disease, treating the disease and treating the person. Sometimes physicians are so focused on treating the disease, and we forget that the disease is not the person, because you can treat the disease and missing treating the person. But if you treat the person, you have a good chance also to treat the disease as well. So Ubuntu can become a system of social protection. There is a fracture when someone gets a life-limiting illnesses. There is a fracture. It's become naked to the community, and we need to bring back the community to the community engagement to protect the nudity of the patient, to bring back the dignity of the patient. And also hope using as a homegrown solution, contextualize. How do we contextualize our palliative care? It's not about to replicate a model from one setting to another setting, but also to understand how the context works. And also in terms of reconciliation, the health institute, the hospital itself, it's a background of a colonial period. So how to reconcile that hospital can become a place when people treating the person before to treating the disease. And we need a decolonizing process on that. So community are the safari concept. Safari means journey in Swahili. It's just a journey. It's nothing with animals. It's just a journey. And we need to understand how that is really important in our sense to understand the terminology, to not narrow the terminology on one thing, but also how we can reconcile both. So this is why I came to write this book, which is available in Amazon, to understand the journey of a physician, a journey of a patient, but also a journey of a family members. When I was starting to bring this idea to welcome family members, my colleagues say, oh no, don't bring the family. The family are very challenging. The family is the problem. But I say, did we try to invite the family? I said, don't try. From our experience, I said, don't try the family. Don't try to bring the family members because family has the problem. Then I said, no, we need to invite them. Then I was starting to invite the family. But you can imagine, I didn't expect when I call a family meeting from an African perspective, it will be between 10 to 40 people. The last meeting I have, 40 people came in the room because they are all connected. It's not about the numbers, it's about connection with the patients. And one of the idea by bringing the family was also to understand the psychosocial distress by taking care of the patient. So this is book also try also to value expertise through personal experiences using empirical evidence. So I came with 12 animal archetypes, which represent different language of suffering, meaning, and solution. Of course, it's difficult to translate, for example, the 5 stages of Elisabeth Kubler-Ross in Rwanda. But if I'm using animal archetypes to understand the language of suffering, meaning, and solution, it's easy for me. And it's easy for the patient because that language bridge between the physician and the patient. So what I'm doing, the first thing is I'm introduce myself and ask the family to introduce themselves. So if the introduction is from the eldest to the youngest, it's a traditional family hierarchy with clear values and strong cultural roots. If the introduction is from the youngest to the eldest, so that indicates the hierarchy is more organized by the most influential person than the traditions. And mostly this meeting is a nightmare. And if introduction is from female to a male, so that the meeting going very well, but in terms of decision making, that will take, will involve extensive discussion. Mostly I'm asking 5 questions. What is the story of illness from the first symptom until now? Because I try to reconcile. I'm saying here, my role is more than to be a physician. It's more also a reconciliation. I'm trying to reconcile the story of the patient to have the whole family there. What does the patient understand about the illness, the patient autonomy as well I'm talking about? what the information was received from other physicians. Try also to understand the community responsibility and about the information. And how do you feel about the care of the patient as received? And I like the fifth question. What are your expectations of me? When I'm asking that question, is only the lion or the lioness in the room can respond on that question. Because my role now is not to determine who has to be part of the meeting. My role is not to define who has to be part of the meeting. My role is to increase my communication skill to be able to talk to the family members. And what I'm doing, I identify who is the lion on the lions of the family. If I understand, if I see the lion on the lion of the family, I know for the next steps, everything's will going well. So let me give you just a few examples. The giraffe suffering is the distance. So during the meeting, you have family members come with unrealistic expectation without considering local resources. It's mostly family members living abroad in US, Canada, and Europe. They came and see at the district level, there is no MRI, clinical oncologist, there is no CT scan, PET scan, there is no chemo. So we don't take it personal, but we know the behavior, it's a suffering. So what the meaning of that behavior? It's they express the skepticism about the local team skills and expertise. They want to relieve their own stress and anxiety by trying to compare what is available in the local resources and what is they expecting from the country where they're living from. So the management, we engage in a confident discussion humbly without surpassing the family's egos. We don't take it personal, we just discussing with the family, with humility. So the hyena suffering is the family members who trying to import the conflict from home to the hospital. So there is conflict between family members, and that impact on terms of dignity, empathy, and care of the patient. People don't talk to each other for years. Parents, children, cousin, uncles. So our interpretation, so the experience is a mixed emotion because the patient is a source of conflict, but also is a source of connections. The family live in the conflict so long time. So now they don't project themselves after the patient will die because that will bring them in terms of reconciliation, and they're not ready to reconcile between them. So what we are doing, it's a language of suffering. We try to focus to work with the lion on the lioness and reduce the number of meetings and have a meeting only with the lion. Another example is the torture suffering among. Is the family members came with a strong and deep belief in potential cure, miracles, and came with a traditional philosophy and traditional healing. There is a strong shield. So our interpretation, the meaning of that suffering, so there is a second chance. There is unfinished work. The patient have been promoted. The patient just get a green card. The patient just get an offer to a new position. They just finished building a house. There is something remain. The patient has to accomplish. It's not possible for the patient to die now. So management, we choose your word carefully to communicate effectively. And one of the examples I'm teaching my medical students, because Rwanda, it's a Christian country, mostly Christian country. So when you go and see this kind of family, please remove your lab coat. You remove your stethoscope. And if it's a Christian family, say praise God. And if it's a Muslim family, say salam alaikum. If it's a Rwandan traditional family, say mwiriwe, mwaramutse. Because when you choose your word carefully, you communicate effectively. Another example is about the chimpanzee suffering, the pretension. You will see family members come with gathering a lot of information from different sources. There we can thank Google and ChatGPT because they came with a lot of information and they act like a physician. For them, acting as a physician by gathering lots of information is the way they can relieve their own suffering. So our interpretation, they mimic healthcare providers to assess family control and alleviate their own anxiety. So our management, we use just simple words to explain complex issues. So the next examples, it's about porcupine suffering. You're talking about the present illnesses and the patient and the family members related to the past trauma. So there is a connection between present and the past. You can feel the present, but it always go to the past. So then we understood for this porcupine suffering, you can train one psychologist is not enough. We need to train the whole community. We need to educate the whole community, to provide the right information that the patient will get each information at each level. I don't have time to talk about the African buffalo suffering, anger, elephant suffering, emotion, hippopotamus suffering, integration, the snake suffering, scapegoat, ostrich suffering, avoidance, chameleon suffering, appearance. Community as my conclusion. So naked but not ashamed. I remember when I was going to see this patient and she was just sleeping on the floor. What we did before to give any treatment, we went to the store and we bought these mattresses and bed sheets and come back because she was dying. HIV/AIDS stage 4, cervical cancer stage 4, she almost dying. And I was kind of discouraged sitting there because the door was the window and the window was the door. And I was sitting there and seeing a reality, suffering. I take just my notebook and just wrote this poem. I'm going to read to you from the book. I feel naked when I see the suffering of family members and caregivers, helpless and hopeless to support the patient as they would wish. I feel naked when I visit patients and family members in social, psychological, and spiritual pain. I cry in the palace of God because I don't know where to start. I feel naked when the dignity and the value of the patient are viewed through the lens of their disease, not their humanity. I feel naked when I see that access to treatment depends on your place in the world. I feel naked when iniquity, inequality, social injustice, and the culture of me prevail over the connection between people and culture. I feel naked when people are happy to publish data from developing countries, but less eager to support those countries. I feel naked when people from developed countries claim that what we are doing is not palliative care. They focus only to the comparison, not the reality of our compassionate effort to support patients and families with our limited resources. I feel naked when I read expression of gratitude, satisfaction, hope, and life in the eyes of my patients and their families, just because we are there. But I'm not ashamed. I'm not ashamed at all. Because we are not beholden to hate, guilt, fear, death, or stigma, but to life, hope, dignity, and Ubuntu. I'm not ashamed because though I cannot do everything, I must do something. I'm not ashamed at all. Why? Because in African setting, when contemporary medical practice are intricately linked with the social culture paradigm, an imperative demand exists for an anthropo-palliative care framework, integrating anthropology and palliative care to foster in deep understanding and community dynamic in diverse spiritual strategies. Because the way people die can reflect how the society lives. So thank you. I would like to thank our partner, Ophira, Nina, our local supervisor, my mentor, Eric Krakow, and the NIH-NSI for the invitation. Thank you so much for your attention.
Wow, just wow. Thank you, Dr. Ntizimira. That is a very tough act to follow. Thank you so much. I really appreciate how how real and compassionate you were through your talk. It was very clear the passion you have for your work, and congratulations. And thank you for sharing your vulnerability with us and actually giving us permission for us to be vulnerable as well. So thank you very much. At this time, I do ask for those of you who feel comfortable to please turn on your videos so we can now turn to a question and answer period. I'm sure you have lots of questions and comments and feedback. As you can tell from Dr. Ntizimira's talk, he is very approachable and would, I'm sure, be welcome to hear from all of you. You can put your questions in the chat, or please just go ahead and use the hand raise function or wave your hand if your video's on, and you can go ahead and get us started. I'll be silent for a moment. I do have a question, but I'll be silent for a moment to see if anybody else wants to go first. Okay, Dr. Ishak, please. And please say your name and maybe where you're from when you give your question or comment. Dr. Ishak, can you hear us? Oh, are you not able to unmute? Apologies, we're not able to hear you.
Maybe you can take another question, then we can come back to Ishak.
Yeah, sounds good.
Yeah, I think.
All right, Dr. Ishak, we'll try to work it out for you.
Yeah.
Oh, wait, he is trying to. It looks like he's trying. Okay, we'll go ahead. Anybody else?
Hello.
Ah, yes,
yeah,
we hear you.
Yeah.
Yes.
Okay. Yeah.
You're on.
Yeah. Thank you very much for the beautiful presentation and very emotional. And it just takes me back to my practice. And I'm Dr. Ishak Lawal. I'm a gynecologist practicing in Birnin Kebbi, Nigeria. So my practice is similar to the presenters, area of practice is similar to the presenters' experience. But from my experience, I want to, one question, then comment. The question is, what is the role of finance in definition of the lion in the room? Because from my experience, finance seems to be the central point. And it plays a lot of roles in terms of some of the decisions. I see aggressive patients, patient relatives showing aggression to cover lacks of money. I see patients being very meek because of lack of money, depending on how they behave. So a lot of times, sometimes we then need to talk to them in terms of weighing. That's finance takes a central role, in my own experience, in counseling patients, because you have some patients that sometimes they have all the money and they want to just do everything and anything for their relatives just to satisfy conscience. Some don't have money, but they don't want to feel guilty as if they are not supporting their patients. So I want to understand, in terms of these definitions, what is the role of finance? Thank you.
Thank you, Dr. Ishaka. From my experiences, I've learned two things: patients' rights versus patient autonomy. And mostly in Rwanda, but similarly in Africa, patient autonomy is very expensive, because sometimes patients are asking so many things which they cannot afford themselves. So, and it's why in that context, by calling a family meetings, I need to make sure that the family understood the patient autonomy, what the expectation, the privacy, and everything. I need also the family to understand where to invest the money, when to invest, because it's not necessarily to bring a patient in India or Nairobi if the patient is almost on terminal care. So that is something really important. So this is why I'm saying my role is not to be only a physician, is to be also to reconcile between the patient and his environment. And sometimes there is a conflict between the patient and the family because of expectation and also local resources. And that's why I'm thinking, and this is my opinion, that Ubuntu philosophy taught me to be a reconciliator between the family. This fracture between the patient and the family has to be bridged. And this is why I'm talking to the family and making sure if I identify the lion, because we are very stoic. We are very stoic society in Rwanda, and you can see the lion and say, "I'm the lion" or the lioness. So I need to poke. How would you say? What is expression in English? To poke the bear out of the cave, something like that. Yes, I need to make sure that I will see the lion, and from the lion we say, excuse me, this is the priority from the patient, and I understand your priority. Let's make a consensus. In that process, I need to renegotiate my power to be able to reconcile patient and family members.
Excellent. Thank you. Satish, over to you.
Yeah, thanks, Mishka. Thanks so much, Christian, for a really wonderful talk.
Hi, Satish.
It's good to see you. A couple of things.
Good to see you too.
One, it's a great talk, as expected, and certainly this kind of emphasis on community. And then I love the way that you categorize these sort of archetypical experiences in these complex relationships, which I think are actually true around the world. I mean, many of these scenarios, of course, happen on a daily basis in cancer clinics in the US. I'm curious, and so it's great to see you not only leading the effort, but teaching a new generation of Rwandan medical students how to approach these really complex situations, because as you know, that's not historically been a part of medical education anywhere in the world, including in the US and Africa. I'm wondering how much you have been able to, obviously there's a worldwide effort to introduce and integrate palliative care at earlier stages of the cancer treatment journey. And I'm wondering how much you have started to do that, because I think this individual community reconciliation need exists even at a much earlier time points as well. Yeah. We commonly, I mean, as you know, we were always impressed by how much misinformation patients were bombarded with within their community settings. And so we would often have situations where a family that had a child with Burkitt lymphoma would refused to initiate chemotherapy that was available and had an opportunity to cure the child because of some experience that someone had with lung cancer in their family. Or patients would initiate treatment, start to do well, go back to their communities, receive all kinds of information about the treatment that they were receiving, and then might make a decision based on that information to leave treatment. So I'm wondering how much you've tried and or been successful at integrating some of these principles at earlier stages of the cancer treatment continuum.
Thank you, Satish, for the question, and good to see you. So this is why we starting this project with, you know very well, Eric Krakow from MGH. We're starting to make sure at early stage, this project will be integrated. And this is why now we've been invited by the Rwanda Military Hospital, where the Rwanda Cancer Center is located. And also we have an MOU with the Rwanda Biomedical Center, which is the institution from the Ministry of Health, to be able to integrate this part of a project. And unfortunately, the last 10 years, the experience is most of the patients we receive came late at the district level and without any appropriate information. And starting there, as you can imagine, was really a nightmare. And because the family already have some information and some misinformation, and this is why our role was really intense at the district level. But we are very happy with this project and working with Dr. Rick Krakow. We took one district at the the rural area and one district and urban. And the rural area is just near, it's a Gichumbi, it's a Byumba, it's near Butaro Hospital, where they receive most of patients from Butaro Cancer Center. And also at Gichukiro district, where there is a Rwanda Cancer Center Hospital, we train clinical oncologists, we train psycho-oncologists, and all the team to say, this is now the time we need to set a family meeting. So you have now the tools, we have the profile of the family members, you know how to increase your skills in communication, so that will be easy for you. You don't need to go and pass by the same mistake I did and the same struggle, because now it will be easy. And the project now as well received, and this is what we are going to do. And now as part of the University of Rwanda, I'm teaching also medical students, and I hope we are planning from the next 5-10 years to make sure that at the early stage, the information from the patient and family members will be integrated as early as possible.
Excellent. Oh, that was great to hear. Thank you.
Yeah.
So we have time for one last question. So Sudha, you will be our last question or comment, and then we will close.
Okay, thank you. And thank you, Dr. Ntizimira, for your talk. And I'm just the whole notion of the animal analogy and the different types of suffering really resonated with me. So I'm a colleague of Mishka's and Satish and others in the center here at NCI. I wanted to ask, are there efforts to develop a cadre of experienced caregivers in your hospital? Because, sometimes, I've done some work in Southern India on this topic. I just feel like certain behaviors that have never existed, learning more about health literacy, communicating within your family, all seems to kind of converge in this stressful time. And I'm just wondering what your thoughts are on that topic, and if there is any effort to do more community-based engagement or by empowering caregivers who can then be your allies, right, as new cases come through. So.
Yeah, thank you for the question. So, because one thing is from Rwanda is everything is based on community. This is the government's policies. Everything has to start from the community to making sure that any patient from any corner of the country will get the same services and the same quality of care as the patient in the rural area, in the urban area. So it's in that context when I was starting to calling the family members, because even myself, as I said, I didn't know about part of my culture, because my training as a physician was only to focus on the disease, not necessarily on the patient, until when I just realized I'm starting to conflict with my own patient and family members, and especially came from Boston when I tried to duplicate the same model, and then I become very conflictual with the family. Then I starting to say, wait a minute, okay, why can I take a pause and starting to learn from my own culture, my own sensibility, cultural sensitivity, and in that context. I just realized my language is not patient's language, and it is not caregiver's language. It's totally different. The way because the language is not about talking, it's about how you communicate, because there are people talk a lot, but they communicate less. Talking and communicating are two different concepts. So, and that's trying to say what will be the best way to communicate. And that's just realize what's connecting me and the patient and the family members. It's a different language. Mostly it's about metaphor. And I just find metaphor very useful, because when I'm mentioning about Aina, even the patient, family members, and my team, we all understand. We are on the same page. We are on the same line. Of course, I don't use animal we don't have here, even in our language. I don't use panda, kangaroo. We don't have those animals here. I'm just use what is available in the country and what is useful in our language. And in that context, when I was starting to using metaphor and those metaphor, and it's become easy for me. And even from my colleague who read the book, they say now it's most helpful. So what I can advise on that context, please try to understand the suffering, the psychosocial distress from the families. The way they behave, it comes from a suffering. It's why I'm saying I don't take it personal. I just understand it's a suffering. Let's take a time to understand the meaning of those suffering. And then you discover the language which is appropriate from each suffering. So by having these 12, I'm telling you, for me, now numbers doesn't matter. I can have 40, as I told you, 40, 50 people in the room. It doesn't matter for me, as long as I know which profile of family members and which language and meaning I need to use to address the suffering. Yeah, I hope I respond to your question.
Yes, I think you did. Yes, she's nodding very well. Yes, and thank you so much. And I appreciate all of you joining and appreciate Dr. Ntizimira, your dedicated time. I'm sorry that we've run out of time, but we will have the recording available. Somebody asked that question in the chat. Yes, it will be up on our website after the session. And this, actually, I couldn't think of a better final session for 2023 for this seminar series. So thank you, Ntizimira, Dr. Ntizimira, for being our last speaker for this year. Look ahead in 24 for our lineup for the seminar series. Also coming in May of 2024 is the annual symposium on global cancer research, and we will be posting information for call for proposals in January for that as well. Thank you all for joining. Thank you, Dr. Ntizimira, and thank you to everybody at the Center for Global Health for making this happen, and best wishes to everybody.
Thank you. Thank you, everybody. Thank you.
Bye.